Good afternoon, everybody. Thanks for joining the Sex and Gender Symposium. I'm going to be giving my talk today on progesterone postpartum women and preventing return to methamphetamine use, applying maternal-fetal medicine's favorite intervention to perinatal substance use. So I wanted to start with what I've been doing for 2 years while I was on the WRHR here at the university. So I'm the medical director of the SUPERAD clinic. The SUPERAD clinic is a substance use specialty prenatal clinic for pregnant and postpartum women. We take care of women across all spectrums of substance use disorders during pregnancy and postpartum. And the goal has really been, and the goal was at the beginning of the WRHR, was to make University of Utah a clinical and research center of excellence for perinatal addiction. So during my 2 years, I took both maternal-fetal medicine and addiction medicine boards and thankfully passed. I wrote some papers. I've had 20 papers published, 2 accepted, and 4 to 10 in various phases of revision, depending on what you call revision. I've submitted some grants. 3 of them were funded, many more were not funded, and I've established lots of collaborators and part of the core faculty for PARCA, which is our addiction research group. I collaborate with Liz Conrad and Sheila Crowell in the psychology department. I have collaborations in pediatrics, in the Utah Department of Health, as well as other institutions. So this, my time has really been quite valuable in terms of being able to make these collaborations across the country and even here at the university. So what we've been doing in SUPERAD in terms of studies, we applied to the CCTS and received funding to do a multi-site study studying the models of care for pregnant women with opioid use disorder. We were selected by the CDC as a site for MATLINK, which is a maternal infant dyad prospective cohort study of these dyads that are affected by opioid use disorder. We are also a site for the MOMS trial, which is a clinical trial as part of the NIDA clinical trials network for pharmacotherapy for pregnant women with opioid use disorder. We are also a site for the CDC randomized control trial for Optimum, which randomizes pregnant women with opioid use disorder to a patient navigator. A state initiative that's funded is SUPERAD Price. That's a perinatal opioid use education initiative and enhanced prenatal care in Carbon and Emery County. Myself and Jerry Cochran are involved in that, as well as Banu Muniappa. And then CPAST is a cord prevalence study that we are collecting anonymous cord samples across the entire state. That is also funded by the state. And then my Utah Public Population Database project is prescription patterns to pregnant women, contemporary patterns in Utah, and that is funded by the WRHR. So those are some of the projects that we're working on currently. So now what? So now I'm working on the new kid in town, which is methamphetamine. So methamphetamine use has steadily increased in the past decade. Utah is one of the highest states for methamphetamine use by women. We rank in the top, certainly in the top quartile for methamphetamine use among women. And methamphetamine use is certainly a Western problem, as you see on the map on the right. We wrote a paper about pregnancy-associated death in Utah, and a quarter of women used methamphetamines that were associated with their death. Most women in this cohort that died, either in pregnancy or year postpartum, were using either opioids or some combination of other drugs or medications, and methamphetamine, like I mentioned, was a quarter of the women. So there's an interesting study. So when we talk about meth, we need to think about kind of how the course of pregnancy and substance use, and I think about it a lot, but just as an introduction, that most women will achieve abstinence in pregnancy from at least one substance, and it's really 83% of women. But that likelihood that women are also very likely to relapse to at least one substance postpartum. And part of that is thought to be a sex-related difference between men and women, that estrogen has so I'm going to review a little bit of hormones. So estrogen has some dopamine-enhancing effects, and it enhances the reward and reinforcement felt by women. Progesterone decreases the response to stress and anxiety and aggressiveness, and is associated with higher levels or associated with fewer addicting behaviors. And allopregnanolone, which is a metabolite of progesterone, acts much like GABA A, which acts a lot like Valium or alcohol in your brain and can dampen a stimulant effect. So the role of micronized progesterone, which metabolizes into allopregnanolone, has been looked at in a group in Yale where cocaine is much more prevalent, and they randomized 50 postpartum women with cocaine use disorder who had achieved abstinence in the last month of pregnancy, and they randomized them to 100 milligrams of micronized progesterone, which is a medication that is very cheap and very readily available and well tolerated, or to placebo. And their primary outcome was self-reported self-reported drug use or positive urine toxicology. And what they found was that the women that were in the placebo group had an increased likelihood of using cocaine per week for the 12 weeks that they were enrolled. And women in the placebo group were more likely to relapse more quickly than women in the progesterone group. So I'm going to be submitting in a month an R21, and we're going to be proposing a double-blind placebo-controlled randomized controlled trial of micronized progesterone among postpartum women, so similar group, but to prevent return of methamphetamine use. We don't have as much cocaine use here in the West, but we certainly have a lot of methamphetamine use. We're proposing to randomize 58 women to a slightly higher dose of 400 milligrams at 200 milligrams twice daily, or placebo, and will include women with opioid use disorder in remission. Our hypothesis is that women who are randomized to the progesterone group will be less likely to return to methamphetamine use and have increased time to return to use compared to placebo. Our secondary aim is going to be to look at serum allopregnanolone concentrations and methamphetamine cravings in the control and treatment group. So we'll be collecting serum hormonal levels obtained at delivery and every other week up to 12 weeks postpartum, and collecting methamphetamine cravings as measured by a stimulant craving questionnaire. And the hypothesis here is that the women with higher serum allopregnanolone levels will have lower methamphetamine craving scores, and this gets a little bit at mechanism. So again, the progesterone, we joked the title of this talk was because we as MFMs like to use progesterone in all different forms. And so it's certainly not something that for MFMs are not used to doing. We do this a lot. And the goal continues to be to make University of Utah the clinical and research center of excellence for perinatal addiction. I'd like to thank my mentorship team, Mike Werner, Bob Silver, Adam Gordon, and Gerald Cochran, certainly the Parka team, the SUPERAD team, and Jasmine Charles, who co-runs and has co-founded the SUPERAD clinic with me. And I'll take any questions. Thank you very much for your attention.